When I think about the workup for a patient, you always have to think in a few different big categories.
We're looking at the ovaries, the uterus, the male factor, diet and lifestyle.
We'll check for over about 500 genetic diseases. We're making embryos. We need to be responsible about it too.
So you are working with Dr. Kelly Beck, Dr. Guy Ringler, Dr. Corrine Chung at California Fertility Partners.
Yep, that's right.
Yeah, and you are new to the scene, but not new to this medicine.
Yep.
But I am really happy that you're here and that Dr. Beck was working with you when you were at Cornell and Dr. Pak Chung, and you were doing some monitoring of her patients. And then she brought you here, or how did that Kismet situation work out?
You're right. Kismet is the exact word for it. So when I was a first-year fellow, I grew up in Los Angeles to kind of set the stage. So I knew I wanted to come back to LA to practice. I did my medical school and residency training at UCLA. But for fellowship, I really wanted to go to the best possible program that I could get into. And Cornell was the gold standard. So that's where I was trying to go. But it was always my plan to come back. So even I'm a planner. So first year fellowship, I was already looking at practices in Los Angeles that I wanted to come back to. My mentor at Cornell, who founded the practice, Zev Rosenwax, anytime he had any patients that needed to come out to LA or transfer care when they moved out to LA, he would always refer them to California Fertility Partners, and specifically to Dr. Beck or Dr. Mars or Dr. Ringler. I thought, wow, that's the practice that I want to go to if Dr. Rosenwax is referring patients there. So I had already started manifesting California Fertility Partners. But of course, as a first-year fellow, it's a little bit too soon to reach out because fellowship is 3 years long. As luck would have it, Dr. Beck had reached out to Cornell because that's where she had trained as well, and asked if there was any fellows who were interested in coming back to the Los Angeles area in 2 to 3 years. So wasn't that just amazing how that worked out? So we were connected, and I was just very lucky to be able to have a spot there. And I'm very grateful to everyone at CFP, specifically Dr. Beck, for bringing me on board.
She has some amazing hunches, that's for sure.
I hope so, yeah.
But you two have similar energy in the way that you run your protocols and the way that you dissect a case and kind of use like a mental checklist. And I figured if we could bring that into this episode, it would be so helpful for anybody listening, because we might have people that are just getting started, or women and couples who have been going through it for a long time, that there will be something that they hear that then can help them run with that and have a pregnancy when they haven't before. So I know that being the holistic provider on the team, I start my conversations very differently. And usually they've already done a workup with the MD, the RE. So let's imagine our mutual case that we have. She's just turned 37. And she's been doing things the holistic way. And she's got 2 pregnancy losses under her belt. What is the starting point for a case like that? So it's not just brand new to fertility.
Yep. So, and most people, like you said, by the time they've come to see me or any sort of reproductive endocrinologist, they've either had, if they're less than 35, maybe 12 months of trying to conceive without success, or over 35, 6 months trying to conceive without success, or in that patient's case, 2 pregnancy losses. She was able to conceive but unable to keep those pregnancies ongoing. So they've been doing this for some time, right? So we need to get to the root of the problem as soon as we can. And if we cannot get to the root of the problem, they fall into this category of unexplained infertility, which is kind of, a catch-all for the people who we haven't been able to find anything for. So when I think about the workup for a patient, you always have to think in a few different big categories. So the first category is the ovaries, because that's where all eggs come from. And so, we have to make sure that women are ovulating properly. And I'll go into the specifics in a little bit. So the first category is the ovaries. The second category is the uterus. And part of the uterus includes the cervix and the fallopian tubes to make sure that both of those things are anatomically normal as well. Then you have the male factor involved as well, and how that can contribute to infertility and or pregnancy loss. Then you have to think about the genetics of both partners, both the egg and the sperm. And then the last category is overall health and well-being, really, right? So we want to make sure nutrition is good for both partners. Their stress levels aren't too high because that can really affect ovulation. They have they're exercising enough, but not too much, because that can also affect ovulation. And
maybe ruling out some lifestyle factors like
exactly
using marijuana.
Exactly.
And maybe when you said nutrition, I think you're screening for, is there an eating disorder or disordered eating?
Exactly. Disordered eating or, and part of that also includes eating the right types of foods too. We want to make sure that, trying to conceive is not the best time to diet. I like to say, your body wants to be nourished because a nourished body will ovulate well. And then you can also hold on to a healthy pregnancy. It's a fine balance with overnourishing, and then we might get some abnormal glucose function tests, and that can affect not only our chances of conceiving, but also the health of the pregnancy. So it's a fine balance there.
Right. It can affect ovulation, right? PCOS.
Exactly.
So we're looking at the ovaries, the uterus, the male factor, diet and lifestyle.
Exactly.
And like implantation or immune response. That's after further you get into the weeds.
It's a little bit of a further deep dive there. It's a little bit more of a very individualized approach for each patient. Not everyone necessarily benefits from like an immune workup right out of the gates. So when we're talking about the ovary then, the first thing is, of course, just making sure a woman is ovulating. So one of the main questions we ask, and actually all doctors should ask any sort of ovulating person or menstruating person, is, are you having regular periods? And that's just a vital sign for us, right? It's like blood pressure, heartbeat, respiration, temperature, menstrual cycle. It's like always the fifth vital sign for any sort of OBGYN. If you're ovulating normally, then you're going to have normal menstrual cycles. And that's already a big step ahead, right? Because women with PCOS, for example, their follicles, they have so many follicles, but they kind of compete with one another. And so they don't release one. Exactly. Yeah. They don't release one because there's just too much competition going on at the ovarian level. So if you're ovulating normally, that's already a big win. The other thing about the ovaries is we want to make sure that the luteal phase of the cycle is also sufficient and long enough.
Which is another indirect function of ovulating properly, right? Because when the follicle ruptures, then it secretes progesterone.
Exactly.
So we want it to be over 10 points typically.
Exactly. Yeah, exactly.
Like a week after ovulation.
Exactly. So the way that Dr. Rosenwack, so I talked about earlier, the way that he used to check the luteal phase is we track ovulation and then we'll check a progesterone level 5, 7, and 9 days after ovulation. If 2 out of those values are over 10, then that's good. That's a good, healthy working corpus luteum, which are the cysts that provide the progesterone. So that's very reassuring. The other thing about the ovaries is diminished reserve, right? Just talking about the number of follicles that you have in general. I know you see a lot of those patients, and we all do.
All the poor responders.
Exactly. Yeah, we all see them, and that's that's why we're in the field that we're in.
And I think it's a function of where we are evolutionarily speaking.
I agree with that.
You know, we have so much sugar and so much stress. And so much expected of us that either the eggs are too scared to come out for a follicle count, or there's not very many of them.
Yeah, it's an interesting way to think about it, right? I've been wondering actually for the last 10 years since I started wanting to be an OBGYN, I wonder if at some point our ovaries will catch up and evolutionarily they'll be better for longer. But we'll talk about that later because they're still catching up from when women were having kids in their early 20s and they think that that's normal.
And dying at age like 45.
Exactly. Right. So maybe one day our ovaries will catch up to what's actually happening in the world. But until then, we don't, most people that we see are either having diminished reserve, meaning that they don't have as many follicles at the beginning of their cycle. And women with diminished reserve will have, in times, poor response to treatment as well. So they kind of go hand in hand, unfortunately. Other things are like cysts on the ovaries. So some types of cysts don't really cause an effect on the follicle count, but things like endometriosis and specifically endometriomas on the ovaries can really cause diminished reserve and a poor response.
Because that is like a blood-filled cyst that's in there.
Yeah, it's blood-filled cyst. And it's not just that it's the cyst and it's taking up space. It causes a lot of local inflammation as well.
Because it's side effect of having endometriosis, probably.
Exactly. Correct. And it's interesting. Sometimes women come in and they don't even know they have endometriomas. They've never had any symptoms of endometriosis, and they'll have diminished reserve. And, that's a whole brand new conversation that we have to have right then and there. So that's, that comes up as part of the workup.
Mm-hmm. Well, whether or not they have both ovaries.
Yes, that's true. Yeah.
Had a number of them only have one.
Exactly. Some people
and they
might
would have no way of knowing that.
Yeah. I don't run into that too much, but sometimes we do see that one ovary just responds way better than the other. And I wonder, and I think some of that has to do with if somebody had a cystectomy earlier in their life for whatever reason, maybe they had an ovarian cyst at some point and their surgeon at the time, maybe they were 18 years old, their surgeon at the time removed that cyst, but for some reason that ovary never really resumed full function again. So one ovary is sometimes quiet, what we call quiet, and doesn't have as many follicles, and the other ovary is doing just fine. So that's another thing that we can pick up. Another part of the ovarian kind of the antral follicle count or our ovarian reserve also has to do with women being on suppressive hormonal treatment beforehand. So if women come to me for fertility preservation, for example, and they've been on birth control pills, or if they even have an IUD in place and it's a Mirena IUD, in theory, and the studies point more towards the fact that Mirenas do not suppress ovarian reserve. We do see that in some women, removing the Mirena IUD or stopping birth control pills for about three months before starting a treatment cycle can really boost up their ovarian reserve before we start a treatment protocol.
Mm-hmm.
Yeah.
To give the eggs a chance to come back online.
Exactly.
And
the
pituitary to regulate
I like the way you
itself.
think about it. Yes, exactly.
Yeah.
We got the eggs come back online. Exactly.
Yeah. Well, the holistic part of the team is good at trying to explain or anthropomorphize what's going on so that the women are a little less scared. This is one of the ways that we calm down this hypothalamic stress that's happening to cause the ovaries to maybe not ovulate properly.
That's so true. All of that kind of in conjunction could do really wonders for the treatment cycle once we get there.
Mm-hmm. I'm thinking of another ovarian condition because it was the one I had, elevated FSH.
Yes, exactly. So that goes hand in hand with diminished reserve too, So when you have the reason why FSH gets elevated, so FSH is released by the brain and it stands for follicle stimulating hormone, right? So it does exactly what it says it does. It stimulates our follicles. When the FSH level is high, it's more of a symptom of what's happening in the ovaries. So when your brain is trying harder to tell your ovaries to release a follicle, to stimulate a follicle. And so it starts at a lower level. And then if your ovaries aren't responding, then it gets higher and higher and higher. And at some point, hopefully, if you respond and you have an egg that's growing or a follicle that's growing, that follicle is making estrogen. And then the estrogen will tell your brain, okay, I'm online. Like you said, I'm online. You can drop the FSH level. And so then the FSH level will go down. A mini version of that happens every single month. But as our reserve goes down in our ovaries, the feedback saying that your FSH level can go down is less and less. So then the FSH level rises and rises. And that's what we see in perimenopause or menopausal women.
Lower
FSH
estrogen levels.
Exactly. Low estrogen and really high FSH levels, over 40, over 60, sometimes over 100.
You know what would be so interesting is if we also could do a serum cortisol.
Oh, yeah.
And then we would be able to tell the patient there is a direct correlation with your stress level and your ovaries.
Wouldn't that be nice? I know. That's when patients ask about stress and how it affects things. I always tell them it's so hard to study that, right? Because how many little cortisol spikes and surges are we having every single day, constantly at different times of the day? But it can't be good.
Right.
It's not. It hasn't been shown to be bad, but it's not good either. But,
right. Well, when my FSH was so high, I was opening well women.
Well, there you go. Yeah.
And I was not in a good relationship. My diet was bad. So much stress, but it was survival level stress. It was just thinking oh my God, if I can't do this, what am I going to do? I've just done this 4-year master's degree.
Yeah.
What else will I do if I fail?
Wow.
So that
your body did not want to reproduce.
That was not a fertile time. But I think I wanted to say that because so many patients will hear FSH is high and they immediately think, oh my God, I'm going into menopause.
Exactly.
And especially here in Los Angeles, aging is terrible,
Sure.
right?
Yeah.
So to think about menopause, they actually think that it's a disease rather than like a puberty phase of life later down the road.
True. Yeah.
We're
It's
all
coming
about,
for all of us.
yeah, well, we're all about normalizing being a woman, and that's just another life chapter.
Exactly.
But this idea of the FSH being that the ovaries are just working really hard right now to ovulate successfully.
Exactly.
That's all it means.
Yep.
Let's segue into the AMH.
Yes.
Though.
Yeah. So AMH is a buzzword over the last few years, really for quite a few years, as a way to check your fertility, right? So that's what it gets kind of labeled as in the media. And I always warn people. So AMH stands for anti-Mullerian hormone. So I always warn people that an AMH level is a marker of your ovarian reserve. It's not a marker of your natural fertility. Again, a marker of your natural fertility is if you're ovulating every month, then your chances of conceiving are the same as somebody else your same age, because they're ovulating every month. It's okay if your AMH is 1 and their AMH is 3, because you guys are both releasing 1 egg every month. Yeah. You're the same age, your chance of conceiving is the same.
Right. Like Dr. Beck would say, a marker for fertility is your antral follicle activity, not the count.
Yeah, that's a nice way to think of
it.
But yeah.
Like, okay, follicles are recruiting. I can see them with my eyes. I'm less concerned what your AMH score is.
Exactly. That's exactly right. And so what AMH does tell us is a marker to how a woman will respond to IVF or to ovarian stimulation. So if I'm somebody who my AMH is 1, for example, that roughly equates to like an antral follicle count of 10. My AMH is 1.5. It's not that great, just FYI.
Well, without knowing how old you are, it doesn't really mean anything.
Yeah, exactly. It doesn't mean anything. And so I have to tell myself too. So, if my AMH is 1, that roughly equates to an antral follicle count of 10. If somebody else my same age AMH is 2, that roughly equates to about 20. So if we're doing an egg freezing cycle.
I've never heard this before.
Yeah, so it's about 10 to 1. So if we have, if I'm doing an egg freezing cycle, if we're both doing egg freezing cycles, I might have to do 2 cycles where she might just need to do 1 to freeze the same number of eggs. So, and I wish that there was something that us reproductive endocrinologists could do to increase that number that we could stimulate every month. We have a few tricks to maybe increase it by 1 or 2 eggs, but not to ever make a 10 turn into a 20.
I do see some AMHs double, but it's a function of food and lifestyle and calming down and getting I think I have seen, and I'm sure you have too, they get one of these markers, be it FSH or AMH initially, because somebody tells them to go in.
Correct. Yes.
They get that. And it scares them, and then they go back to retest, and it's even worse.
Interesting.
Another way of
interesting.
Another way of saying, look how the emotions and the fear just like makes it just
how interesting.
go in the wrong direction.
And on the other hand, like you said, once some people start eating well, or start exercising, or doing starting acupuncture. Their AMH can really improve. Calming
their nervous
whatever
system.
they can do to help calm their nervous system. You can see a rebound in AMH. Another really interesting example was a patient of mine who was on a very strong rheumatologic agent. She was undergoing embryo freezing a few months after she had stopped her medication too. She had waited a few months to start. Her outcomes were not that great. She was diagnosed with diminished reserve. She moved to LA and wanted to further do embryo banking. When I was reviewing her records and talking to her, I was like, oh, this will be a tough case. So, I was prepping myself for that. I did her ultrasound, and I had to do a couple of double takes because her AMH had tripled. Her reserve, well, I didn't know the AMH result right then and there, but her antral follicle count at the time of my ultrasound had tripled. And I think it was just more time off from the medication. It's nothing that I did. I don't think it's anything that she did, but it was this medication that she was on that was suppressing her still further than, Western medicine had told us that it would suppress her. So just sometimes giving time and, whatever. It's a miracle.
I tell them, and I'm saying this on almost every episode, but it is possible to become more fertile over time, depending on what we do with the time. For her to perceive that going to LA is going to be a happier place to live or whatever. I mean, I know that this podcast is about the Los Angeles community, but we know that this condition is definitely not limited to Los Angeles.
Yeah, that's true.
But here we are all kind of friends.
Yeah, that's
and,
true.
We really embrace the holistic, and we've spent like the last 20 years bridging the Eastern and Western.
Exactly.
So who knows what it was for your patient, but something shifted for the better.
Exactly. And I don't want to make it seem like that's a common thing that happens, right?
Exactly.
We have to be very realistic too. She was in a very specific circumstance, and, it's wonderful, but definitely whoever's listening to this, if people are, that's not a very common, that's a very rare thing to happen. I should just say
expectations are officially managed.
Exactly. Expectations are managed.
They need to be. And yet it's like, we really don't know the empowered individual, what she can do once she decides that she's not going to just be the general population statistic.
Exactly. Yeah.
Right.
It's the balance of putting in the time to optimize all factors with managing age and when you want to try to conceive and how many kids you want to have. And, that's where the collaborative union
conversations begin. Yeah. And also helping the women to open her heart and her mind to using another woman's eggs. So that's still in the conversation of ovarian aspect.
You're right.
Of the
that is part of the
workup.
Ovarian aspect of it all, because either right out of the bat, I never really bring up donor egg at the first visit, because that takes some building of trust between the provider and the patient. But there are definitely some patients who I think they know it themselves that they, may need to go down that route. And so I'll ask them, do you want to talk about it today, or do you not want to, or should I bring it up later? And, then I'll get a sense from them. But most people, I think, want to try at least themselves as much as they can, do everything that they can, and then kind of exhaust that option and then move to that, which is a very personal thing. Yep. Yep.
Yeah.
Exactly.
So
I think we did all ovaries. Yeah, I think so. Ovaries are a really big part of it. So it did deserve a big chunk of our time.
Well, that's the potential.
Exactly.
That's where all the potential exists.
You're right. Exactly.
And then there's the receptacle.
Exactly. Then there's the uterus. So the uterus is a very forgiving organ. The ovary is not so forgiving, right? The ovary is very prone to all this oxidative stress and damage. And our follicles have been sitting there since we were 6 weeks pregnant inside of our mom. So, just very prone to all the antioxidants and the POCs, PBAs, all VOCs that happen to us. But the uterus is in a constant cycle, always growing, shedding, and that's why postmenopausal women can carry pregnancies, right? We can manipulate the uterus to carry a pregnancy. It's very forgiving. But there's a few things that we can do to optimize the uterine environment too. So the main one is, of course, just checking the inside of the uterus. So there's I personally like to do that via a saline sonogram. So I use a 3D probe, a 3D ultrasound probe. We infuse the uterus with some saline. It's not comfortable, but shouldn't be painful either. But it's definitely not comfortable. But it helps kind of, if your uterus is like a balloon, like a deflated balloon, kind of this way, like a deflated balloon, we insufflate it so that we can now see inside the balloon like a water balloon. And so we can see things like polyps, fibroids, scar tissue. That's generally the main things that we're looking for. Septums, exactly, like a septums, arcuate uteruses, which is a normal variant, but we can at least distinguish between the two if it's an arcuate or a septum. We
have had a couple of 2 uteri patients that have 2 uteri and 1 vagina.
Yes, exactly.
So if you go through the vagina, how would you see, would it be 2 cervices they would
Sometimes they have 2 and sometimes they just have 1. There's so many different variations of Mullerian anomalies.
Yeah. So is that an HSG finding? How do you know that there are 2 uteri?
You should really be able to pick it up on your ultrasound, just a generic ultrasound as a first marker. You want to you'll clearly be able to see that there's 2 areas where endometrial lining is growing. Then the question is, what does this mean? Because the ultrasound won't tell you what the contour of the uterus is, what the actual shape of the septum is. Is it a septum, or is it actually a bicornuate uterus where there's 2 separate horns? Are there 2 cervixes? Because some people have and some people don't. That requires just a good physical exam too. The best way to diagnose a Mullerian anomaly is by MRI.
Right.
Yeah. So that's just the gold standard. You can put people through the HSG if you need to get that diagnosis, because you sometimes still want to see tubal patency. But it would be really hard for the person performing the HSG if there's 2 cervixes and you didn't tell them what to expect too. So that's a separate conversation.
And that's a rare
It's
finding.
more rare, definitely more rare. Septums, in the case of recurrent implantation failure or recurrent pregnancy loss, are one of the most common causes of recurrent pregnancy failure. So for our case, bringing it back to her, that was one thing I definitely wanted to know kind of right off the bat. Does she have a septum? She does not. Right. But we ruled that out.
And the reason why those septums cause these early losses is due to where the embryo implants.
Exactly.
Right?
So if you have a septum, it's up at the top of the uterus near the fundus, we call it. And that's where embryos like to implant. So if it implants onto the septum itself, the septum's not as well vascularized or perfused as healthy, normal uterine tissue. So if a pregnancy is trying to grow there and it's trying to establish blood flow, then it may not. And chances are that could lead to an early loss. Yeah.
So doing the HSG will usually pick that up. Dr. Beck's episode explained how the view that she has, a sagittal view of the HSG, is where she found those divots and septums residing, not in the technician reports.
Yes, exactly. I know exactly what she's talking about. She does it on her ultrasound as well. So when you're looking at the ultrasound, you want to see sagittal, but then you also want to see transverse as well. So you can actually get a good sense of what the lining pattern is doing, because you'll see the septum sometimes as the pattern diverging. And it'll be, oh, there's something going on. Now there's 2 areas. And some of that might be a normal arcuate uterus, but some of that could be a septum as well. And that's really important to see. I learned that from her.
I learned it from a patient who was doing an ultrasound on video for the SEED program.
Oh, amazing.
And Dr. Beck ran out into the hallway and she said, she will never conceive. There's no vasculation in the upper 1/3 of her uterus. And I was like, oh, okay. After 3 years of trying at another doctor's office,
oh wow,
I'm going to have an interesting follow-up conversation with her. Yeah,
good to diagnose it.
Right. Well, that's why we're talking about it on the podcast, because listeners will now know, oh, wait a minute, I want to go rule this out. Do I have a septum?
Rule that out. Exactly.
Because it's so easy to resection and remove it.
Exactly. It's very simple outpatient procedure with the hysteroscopy.
Right. What's it like?
So so every septum is unique. even septums are unique. So some septums go all the way down to the cervix, and some septums will just come halfway into the cavity. The ones that come down to the cervix, you have to make sure that you're able to safely kind of, I don't know how, I'm trying to visualize this for you because I like to operate. So if it's kind of like, if it's kind of like this, you have to gain access to this bottom part here, make a little hole here with before you even start to resect, and you do that very safely while you're in the operating room.
The cervix?
Right above the cervix.
Okay.
Right above the cervix into the uterus.
Cervix.
Exactly. So you kind of put an instrument through one cervix and kind of tent that little bottom part, and then you cut into it just a touch. So now you can put in the hysteroscope, and with the hysteroscope you can actually just start to shave away the septum. And it's actually really beautiful because as you start to shave away, the uterus doesn't like it. The uterus doesn't want the septum there. So the uterus just naturally starts to expand away too.
In that moment,
you'll see it happen as you're operating, and you'll just safely, you have to be very safe, right? You have to make sure that there's nothing, we're not going to pierce through the top of the uterus, but you can just slowly and gently kind of shave away through the septum. Once you get to the top, you'll see a very nicely preserved cavity. The reason why we do the MRI beforehand is to make sure that it's a septum and not a bicornuate, right? Because if it's a bicornuate, then there's no uterine muscle at the top. Then you would just puncture through the uterus.
Right.
And that's very dangerous. But we'll confirm with the MRI that it's truly a septum, and then we can shave away. And then now we have a large, nicely open cavity. We want to make sure that the cavity doesn't compress on itself and we get scar tissue again.
So enters the balloon.
Enters the balloon, exactly. So you can do a combination of estrogen, the balloon only, or a combo of estrogen and balloon. The studies have shown that all 3 are kind of equivocal. I was trained to do both the balloon and the estrogen at the same time. So that's what I tend to do unless there's a reason not to.
So then you use the estrogen, the lining thickens, and then you deflate the balloon stent and it comes out.
Exactly. We use the balloon stent for about a week to keep both sides apart. Because if you have 2 sides that have kind of like a rough edge, chance of them adhering back together is worse. So that's the point of the balloon, like a mechanical separation. And then the estrogen is like a hormonal Band-Aid. So it gives you, the uterus loves estrogen. So it helps the lining grow with the estrogen. And then you remove the balloon a week later, the estrogen continues for about 21 days. The last 7 days we overlap with progesterone. So that once the progesterone is off, we have a bleed. And then hopefully everything's looking nice and pretty for the next
Ready
month.
to go.
Exactly.
And I can't tell you, I don't know, maybe I've seen it 100 times.
Yeah.
It's a lot.
Yeah.
Of then the lining comes in and then the woman conceives and doesn't lose it.
Exactly. Yeah.
So drats that our mutual patient didn't just have a septum.
I know. You know, sometimes it's I have a very good friend who had a pregnancy loss in the early second trimester, was subsequently then diagnosed with a septum. And I was telling her, you know, I was like, it's such a hard thing to say to somebody, because I was like, I'm so glad that we found something because we can treat it. But damn, it sucks that this happened to you. But now she's carrying she's about to enter her third trimester with her other child, you know.
Another story of how if you have a septum, you need to know and need to have it removed.
Definitely.
And we should say, like, these septums don't just start growing in there. They are undifferentiated embryological tissue from when you were in your mother's womb.
Exactly. Yeah. It's not something that you're doing that makes you grow a septum, not like a polyp that are just like skin tags. We just remove them. They might come back, but you know, that's easy to manage. Fibroids also just grow as we get older in some women, but septums have been there since you were born. And there's not really any way to, unfortunately, know.
Yeah. One possible way is that those women, and the women wouldn't really know it as an individual, but as a practitioner, when they describe that they have always had a light flow.
Sure.
Because 1/3 of the uterus isn't creating blood to bleed.
Interesting. Yeah, that's a good way. Also, if you have sometimes some Mullerian anomalies, not septums, but if you have a bicornuate uterus or a full didelphys uterus and you have 2 vaginas even, some women who use tampons will have bleeding around their tampon. That's another really good way to kind of like a buzzword. When we hear that in women, we're like, oh, okay, let me just make sure that they don't actually have 2 vaginas. You know, like, these are just the little things that I learned. One of my mentors at Cornell did a lot of Mullerian anomaly cases. So we saw a lot of that with her.
Oh, how exciting.
Yes.
It
was exciting.
When I was in college, I did a report on uterine septums. And I then went into molecular biology. Like, I had no idea.
Wow,
it was just
how interesting.
It was a reproductive physiology class.
So you've been wanting to do this forever.
Yeah, that was like 1991. It's so crazy.
There's a really good tool on ASRM's website called the Mullerian Anomalies Classification Tool. And Samantha Pfeiffer, who's the mentor I was just talking about at Cornell, she's like the guru of Mullerian anomalies. She put that tool together, and it's so interactive and amazing. And there's so many different versions of Mullerian anomalies, and the classification before that used to be very black and white, and she's introduced all the levels of gray that she's seen in her career, and it's been an illustrious career. So if anyone has a Mullerian anomaly or is concerned or wants to learn more about it, I would recommend that. Yeah.
So who knew that not only do we have the PCOS spectrum, we have the uterine,
the full spectrum of Mullerian anomalies as well. Yep. The things women have to go through.
Yeah, it's a lot. So with the uterus, there's endometriosis. I know how Dr. Beck starts to get suspicious about that.
Yeah, exactly. So especially if you see different types of endo, you see really anteverted or anteflexed uteruses. Some of that could be normal, but you know, then if that's what we see on ultrasound, we really have to diving a little bit deeper with patient symptoms. Like, is this ultrasound even painful for you that I'm doing right now? You can do a bimanual exam and actually see if the uterosacral ligaments are very tender on the bimanual exam at that time. How painful are your periods, really? Like, tell me, like, truly, how painful are they? And has it been painful the whole month? Really dive into that.
Sex, painful bowel movements.
Exactly. Yeah.
Yeah, and it's because those endometrial adhesions are tugging the uterus over to one side.
Exactly.
Or pulling it back towards the sacrum.
Exactly. That's exactly right. So then you start worrying about that as a potential etiology. And so we have a few tricks up our sleeves that we can do before going to surgery to try to optimize. But sometimes women need surgery. And it's a balance of timing their ovarian, what their ovarian reserves look like, how old they are, if they have endometriomas and not wanting to resect too much of their ovaries beforehand. So very individualized approach for the women with endo.
But first, they need a diagnosis.
Yes.
And this is sad but true, but changing,
Yep.
that the fertility doctors, because of IVF, maybe they will try Lupron, Depo-Lupron suppression first. And maybe they will rule out with like a Receptiva to see if they have BCL6 elevated markers. But no IVF doctor wants to say, hey, I think you might have endometriosis.
Yeah.
And no patient wants to hear that either.
Yeah, you're
because
right.
it means potentially a laparoscopy and some time for healing.
Yeah.
But that being said, the outcomes, if the reserve is not at risk of being diminished, those eggs and the egg quality, the outcomes are so
Could be
good.
so much better.
Yeah.
It's a very, everything you said is right, spot on. And so it's just a conversation with the patient about what risks they are willing to take. And it's a very calculated risk benefit for every single person, and every patient and couple responds to that risk differently. So you'll see some patients who want to go ahead and try to do a couple of IVF cycles before they do any sort of excision surgery. There's people who want to avoid surgery by any cost, even if that's recommended, and so the most that I'm starting my practice now and feeling very attached to my patients, which, is, it's a very interesting thing to make some recommendations for patients. And then, they're not there yet. They don't want to do that yet. And then it's just an ongoing rapport that you build with them. And at some point, maybe they will be ready to do that. And, or I'll learn from them and they didn't need to do it, and every single endo is not the same for any single patient.
No.
And some women, like I mentioned that first case, she had endo, she had no idea. Right. And she had no idea she had endo. Whereas, somebody else definitely knows they've endo. They've had endo for years and they know that, and their reserve is so low. So it's just
I
very
knew that
unique.
I had it.
Yeah.
But my doctor told me, we're not going to operate on you until you're ready to try to have a baby. And I was like, look, I am not in a relationship. That part of my life isn't going well at all.
Interesting.
And I am almost fainting on cycle day 1 of my periods.
Oh my God.
And I would have to go to his office because my cervix was really tightly closed, stenosed.
Yeah.
And he would have to see me completely pale, about to faint. And he would use this very long Q-tip and pull the blood clots out so that then I could go back to work, because there was stuck black clotted blood.
Oh my goodness.
And I was in so much pain. I would vomit.
Wow.
It was such an obvious case of endometriosis.
Yeah.
But even that took me years to get diagnosis and surgery.
I really, really hope that that's getting better. I mean, I know it is in a lot of places, but it's still not quite there yet.
Right.
Yeah.
Sadly, but not for a lack of us trying to bring awareness.
Yes. Yeah, exactly. We're doing our part. You're doing your part.
Yeah. I even have a class called A Holistic Guide to Healing Endometriosis Inside Seed Fertility.
There you go.
It's not saying, here's how you treat holistically. It's here's how to make a decision about whether or not you want to pursue figuring out if you have it.
Yeah,
and then here's a list of vetted doctors.
Interesting. Yeah.
Here's what to take to the hospital if you decide to do the surgery. Here's the potential benefits. Here's some foods to eat to keep the inflammation down afterwards, so that once you get that clean bill of health, you can prepare the womb to be even more receptive.
Definitely.
Yeah, right. So,
yeah, endo's, we both sighed because endo's tough. Yeah, it's tough. And it, especially if you don't know that you have it until you're seeing a fertility doctor, it sets the treatment plan is just not like, we do IVF for the next month's a transfer. It can sometimes just take longer.
Right.
But we're really just trying to optimize all outcomes possible.
Yeah.
Yeah.
I think of it as an evolutionary problem.
Yep.
And while I think that it's undifferentiated embryological tissue, I also don't think that our diet and the foods with the microplastics is helping it at all.
Yeah, I agree with that.
Adhesions, right? Gluey, sticky. So gluten and sugar and plastic mixed in. So,
I know.
I mean, like,
It's like
until
we can't avoid them. It's so hard. It's so hard to avoid them. So it's such a hard thing to tell patients too. But
I try to
we can
help
try our
them.
best.
Yeah, well, I
Yeah.
try to help them because avoiding isn't really possible, but we can cleanse with green foods,
Yep.
leafies, celery, asparagus, zucchini, things that are full of cellulose that can bring out unopposed estrogens to try to take some of the sticky and the inflammation out.
Yeah, that's
It's not,
great.
I'm not saying that an asparagus stalk is going to remove endometriosis.
Yeah. But maybe long-term use of just healthy living can decrease inflammation. Yeah.
And for people that are listening just out of curiosity and they have teenage girls.
Yeah.
Like my daughter, she jokes that no matter what, if you're coming to my house for dinner, there will be arugula on the plate.
That's great. That sounds delicious. Delicious and healthy.
Subtle ways of detoxifying the liver and the blood.
Exactly.
Right?
The other component of the uterus is the fallopian tubes. So that's what the HSG is really good at. Gold standard for kind of diagnosing hydrosalpinx or tubal occlusion. And that's kind of a very well understood aspect of fertility that we should remove any hydrosalpinx. Yeah.
Right. And those fallopian tube disorders were really the reason why IVF was created, right?
Exactly. That's exactly right. So you would think, why do I need to remove tubes if I'm doing IVF and kind of bypassing the tubes anyways? And the reasoning behind that is that hydrosalpinx are just dilated tubes, and they anything that's dilated anywhere in the body that has a blockage or a stoppage, it has a buildup.
It can fill up with fluid.
Exactly. Fill up with fluid and inflammatory markers. And so where is it going to go if it can't go out of the tubes? It's going to go into the uterus, all of that stuff. And that's been very well established with studies from, I think, the 80s or the 90s even, that before I was in the field. So it's very well established that those tubes should be removed prior to doing an embryo transfer. And I mean, it's tough even when trying to conceive, even if you have one tube open on one side and the other one's blocked, we can try to conceive naturally. And it's also been well documented that a left tube can pick up an egg that's released from the right tube and lead to a pregnancy. But having that hydrosalpinx there will always be something else on our checklist in our brain that say, okay, if we're still having trouble conceiving naturally, we should remove that even before going to IVF.
Yeah, due to possible rupture or the
risk of ectopic is higher, your
infection,
and then your risk of just not being able to get pregnant.
Because that part of the body is very intuitive. It knows when something is off.
Yeah,
and
that's true.
Yeah, I think that's why
it's very delicate.
Yeah, I think that's why we have this rise of reproductive problems, especially in the post-pandemic era, because our survival, if it's at all perceived as threatened somehow, then that part of the body will close down so that the nervous system can be more alert for being able to protect us.
Yeah, that's true.
Right?
We've seen a big rise in people coming in for egg freezing and embryo banking, even sperm freezing after the pandemic. Kind of it puts our mortality into perspective, I think, too. I was like, okay, I mean, there's more to it than that, too. It was a year or two of people not meeting partners, not even being able to progress and trying to find a life partner to start families, too. But how amazing that this technology exists that we can kind of freeze time. It's not an insurance policy, but we can kind of freeze time to let our eggs stay where they are.
Right. It's crazy.
Yeah.
Okay. So are there any uterine factors that we have forgotten that you wanted to mention?
I think that's good.
I
think
do
the
too.
uterine factors are good. We can talk about male factor.
Oh, wait. Before we leave uterine factor, we can't forget polyp because that's our mutual patient.
You're right. Polyp.
Weeds in the garden.
Yes, exactly.
Polyps.
So polyps are just little benign growths. So, I mean, 99.9% at least for our patients our age, in our patient population, 99.9% benign. But they're just little growths that can come up in the uterus. And just like septums, just like fibroids, they're not vascular. So if an embryo implants near on a polyp, it could lead to not pregnancy or, maybe like a biochemical. It's hard to know what it could lead to, but we know that we don't like them in there.
Right.
If we're transferring a precious embryo back into a uterus, we want it to look pristine. And polyps are definitely one of those things that we like to remove beforehand. The fibroids are another category. So if you look up like the fibroid FIGO staging, you'll see kind of the locations of where the fibroids are. But FIGO stage 0 or 1 means that it's either completely inside the uterus or more than 50% of a fibroid's inside of a uterus. And those should be removed for all the reasons that we've mentioned before. It's just not a good place for an embryo to implant. And there's even good consideration that fibroids also have their local inflammatory response too. So even if an embryo implants further away from the fibroid, it might have an inflammatory response that would make it not suitable for an embryo to implant and then adhere. So removing those fibroids, there's some. If you can remove a FIGO grade 2, meaning that less than 50% inside the uterus, that's definitely recommended as well. A little bit harder to do hysteroscopically, but in the hands of a good surgeon, you should be able to. And anything intramural, so FIGO grade 3 and above, the data doesn't really show that you need to remove those. So we generally recommend not removing those. Yeah. If you have a lot of them, that's another consideration.
I had a patient who had 40 removed.
Wow. Yeah.
And that left her with no vasculation.
Yeah. I bet her uterus was not the same as it was before.
No.
It makes it really tough.
Yeah. It's a sad story.
Yeah, I'm sure. And then you get adhesions and all of these things that kind of come along with that.
Right.
But again, for our listeners, not the norm.
That is not the norm.
We're talking about the extremes of cases sometimes too, but yes.
One time in 23 years.
Exactly.
Yeah. We also have a subchorionic hematoma, SCH, to be concerned about, but that's not part of the standard workup.
No, but it's an interesting thing to talk about because it happens very, very often. So the subchorionic hematoma is what happens during a pregnancy. So after we've had hopefully a successful embryo transfer or a good pregnancy from an IUI or natural conception too, we're always monitoring our pregnancies very, very closely in our world. We're seeing people at 6 weeks, 7 weeks, 8 weeks before we graduate you on around 9 or 10 weeks. And because we're monitoring so closely, we probably pick up on all of these things like subchorionic hemorrhages that probably a ton of women have, but they're not seeing their OBGYN until 10, 12 weeks when they've already resolved. So when I see a patient that has a subchorionic hemorrhage, the way I like to explain it to them is that your pregnancy needs blood flow, right? And it's going to get blood flow from you and from your uterus, and the uterus is very vascular. So while the pregnancy is trying to, and the way that pregnancies establish blood flow, it invades into the uterus. It's like a little parasite. It invades into the uterus and it breaks down the blood vessels from mom. So if you're breaking down blood vessels from mom and this pregnancy is trying to also make all these new connections, by nature, there's going to be some blood flow that comes out when your vessels are trying to establish a firm connection. A majority of that time, that's just reabsorbed by the body and you don't ever really see it. Another I think about 20% of the time we'll see it, 10 to 20% of the time we'll see it as a subchorionic hemorrhage. And
do you mean that it bleeds out?
Not necessarily, just actually having it when we see it on ultrasound, even just having it. If it's above the pregnancy, before the cervix down here, then you don't always necessarily see bleeding, right? Because the body's just going to reabsorb it. If the hemorrhage happens to be on this lower part, it's going to take the path of least resistance and you might see some blood coming out of the cervix and you'll have some spotting or heavier bleeding too. Those pregnancies we just keep a very close eye on.
Put the patients on bed rest.
Yeah, it's a modified version of bed rest, definitely pelvic rest to no intercourse, no tampons, nothing going inside the vagina. And then yes, a modified version of bed rest as well, because too much bed rest is also not good for pregnancies. Pregnancies like activity, but we definitely don't want to do anything that maybe in retrospect, we think maybe we shouldn't have done this, right? Maybe it's not so much that it's going to cause a miscarriage, but it's a little bit more for our peace of mind. Was lifting that heavy thing what caused this miscarriage to happen? Probably not. But if I was somebody who had a loss, I would think about that. So that's why we recommend like a modified version of bed rest too. But the good news is that a vast majority, over 90%, 95% even of pregnancies with subchorionic hemorrhages go on to have a full term delivery. Yep.
Thank goodness.
Yes, exactly.
But that's because we've learned okay, calm down.
Exactly. Take it easy. Yes.
What the effect of gravity is on those kinds of cases is immediately impressed on that woman's brain.
Exactly.
Oh gosh, when I stand
take
up,
it a little bit easy.
Standing up and gravity will pull out some of the blood clot. Sometimes.
Yes. Oh, totally. Yeah. They're like, oh, I had blood clot. I was like, would you just get up? Yeah, that's probably what happened. Yeah, the gravity of just the blood that was pooling in the vagina kind of coming out that way too. Yeah.
Mm-hmm. Yeah.
Tough cases.
Right. A tough
We're all
field.
thinking about the patients that we've had with these things. I'm sure you and I both.
Yeah. We've learned from
Yeah,
them.
exactly.
And then we can help other women know what to do.
Exactly.
So let's leave the uterus if you're
Yeah,
ready. And then let's talk about male factor.
Yes. So male factor, I leave the crux of male factor to our male urologists or our fertility specialists. And what's beautiful is that we work in such close harmony with them. You're always just a text message or a phone call away, and always really willing to see our patients, which is so lovely. But oftentimes for many men, their first line of any sort of fertility workup is with us, the female, reproductive endocrinologist. And that's with the semen analysis. And with the semen analysis, there's 4 main factors that we're always looking for. The first one is volume, whether to be, again, not too much, not too little of the semen volume. Then we're looking at concentration, which we like to be at least over 15 million. Motility, which is just over 40%, and morphology, which is what the sperm actually look like. And we're very generous with this number. We only want above 4% of the sperm to be looking normal. So if you think about those numbers, right, it's very forgiving.
Well, it's also just how women are, like they can get beyond looks.
Yes, exactly. That's exactly right. So,
the looks are not as important, but screening out the ones with 2 heads.
Exactly. The ones that are round, not usually like them to be a little conical shaped.
Mm-hmm.
So the tip of the sperm of the uterus is like a cone. So the
tip of the sperm.
Yeah. So because men are not like us, men are constantly making sperm all day, every day. Sperm is very affected by environment. So I had one of the male urologists at Cornell once told me that even 30 minutes in a hot tub can really affect someone's sperm count for the next 3 months, because sperm is on a 3-month life cycle, just like the egg. So 3-month life cycle. So the testes exist outside of the body for a reason. They don't like to be warm. So that's why things like hot tubs, saunas, wearing tight clothes consistently. We always ask people, do you drive for long distance? Are you a truck driver? Are you driving for 18 hours a day? Because then you're just sitting in this heat this whole time. Those kinds of things can really affect sperm quality and quantity, and hot tubs and saunas, that type of thing.
Yeah. Men run warmer than women.
Do they?
Generally speaking.
I didn't know that.
Well, if you're cold, your husband isn't he usually able to warm you up?
I'm actually the warm one in
my
relationship. Okay. My husband nestles up to me when he's always touching my legs. Yeah.
Okay. I got that wrong, but
no, but men, totally true.
Yeah. They have, they're just in Chinese medicine, at least we ascribe yang characteristics, right? Which is the warming aspect to male.
How interesting.
And then women, then they're like the moon, the cooler.
I love that. I like that way of thinking about it. I'm going to think about that today when I'm home. So the sperm is definitely, so we're looking at those 4 factors. And if any one of those 4 is abnormal, we always have a little conversation with the patient. How abnormal is it? And the first line is usually repeat it again. And if patients have had any sort of initial flag on when you're getting their history, because we always get the male's history as well, any sort of flag, are they on, Rogaine, Propecia? Are they smoking? Are they smoking marijuana? Are they doing any sort of, their lifestyle things like working out too much or, hot tub saunas, that kind of thing. Mm-hmm. We always want to adjust that before their next semen analysis.
Yeah. How about things like blood pressure lowering medications and pharmaceuticals that they need to take? That
I will leave to the male specialists, because that needs to be very finely titrated, because obviously they need to be on these medications for a certain reason. And that's going to take kind of like a longer term, like therapeutic relationship with somebody who can monitor things closely for them. But, having untreated hypertension, untreated hypercholesterolemia, those things can definitely affect sperm quality as well. So whenever I talk to men and I ask them, do you have any medical problems? I keep it very vague as a first question. And I would say most say no. And then my follow-up question is, when's the last time you saw a doctor? And then like, it's been 5 years, or I've never seen a primary care doctor. Then, you got to go. Because if you have diabetes, high blood pressure, high cholesterol, that can definitely affect your sperm quality as well. So that's just part of taking care of like the holistic male then at that point, right? And then I always like to tell them, you're trying to start a family, you need to be in tip-top shape, not just for trying to conceive, but also for your children that you will have too. We all need to be in tip-top shape.
Yeah. So would you be the one to rule out a varicocele?
I would not be the one to rule out a varicocele. But if my second semen analysis is abnormal, again, then I'll refer them to a male urologist.
Okay.
And that's after speaking to male urologists and saying, when should I refer patients to you? And that's kind of been the standard of care. Of course, we can refer after the first abnormal semen analysis, but if 2 are abnormal, then it's time to go, because maybe the first one, maybe they were sick the week before and their sperm is so prone to, the environment that even being ill, even having like a mild viral flu can affect. So even if the second one is abnormal, then we'll definitely refer over, and then they can do that workup for things like varicoceles and any sort of other abnormalities that could be causing low sperm count, motility, or morphology. Yeah.
Right. Yeah.
Other things that, kind of for our mutual patient, one of the things that's kind of coming up more in research now is checking DNA fragmentation for men.
Let's talk about that.
Yeah. So DNA fragmentation is, it's present in all sperm. And sperm is
to some extent.
To some extent, yes. It's present in all sperm, and it's just a sign of oxidative stress on the sperm. But there's been some thought now that if a male has a high DNA fragmentation index,
higher than
20 usually, every protocol or every test site has a different cutoff. But the one that we send out to, I think, is 20. So if it's higher than 20% DNA fragmentation, then you get this diagnosis of increased DNA fragmentation. And there's a thought that maybe this has not been completely panned out yet in the literature with their studies, but if you have a high DNA fragmentation, maybe it could be leading to recurrent implantation failure or recurrent pregnancy loss. Sorry, I'm going to say that again because that's false. So there's a thought that if you have high DNA fragmentation, it could be leading to recurrent pregnancy loss. And so that's definitely part of the workup to do for anybody that you're concerned about that. At least for me, I know there's definitely some people in the field who say that the data is not that good and it's not conclusive yet. So I agree with that as well. But I'm more of a turn over every page and I turn over every leaf type of person. So I do tell my patients before I order it for them that this is just another thing that we can do to rule out. And if we see a high DNA fragmentation, then we'll act on it. But if not, then good. It's another normal thing, right? And then at least we can say that we've crossed that off our bucket list or crossed that off our checklist. The last thing I want is, 6 months from now, then we do it and it's abnormal. And then we're kind of chasing our tail.
Yeah.
Yeah.
Because DNA fragmentation can be improved with antioxidants.
Exactly. With antioxidants. If
Male
it's
vitamins.
really high, you can...
really high meaning like over 50%?
I think over 50%. If it's really high, then your male urologist may even talk about doing like an aspiration of sperm to use, because the DNA fragmentation increases as the sperm goes from the testes through the epididymis, through the ejaculatory duct, and out through the penis. So every step along the way, your DNA fragmentation goes up, because every step of the way, there's more oxidative stress. So that's why they may do a sperm aspiration through the epididymis instead to decrease the DNA fragmentation. So that's something, I mean, obviously I wouldn't be managing that, but that's from my learning. That's
right.
maybe
Which
something
is
that we would do.
That's another reason why Dr. Paul Turek says that IVF is the worst thing that could have happened for men's health, because if we can just go right into the testicle and grab a biopsy to grab the immature sperm and then circumvent any kind of figuring out why.
Yep. I agree with that. I totally agree with that. It's so funny because almost every day I'm like, okay, that's okay. IVF can overcome this mild male factor. It'll overcome this mild male factor. But there was an interesting, just like I said earlier, that the periods are the vital signs for women. Semen analysis, I bet there's a lot of urologists that think it's a vital sign for males. And if there are abnormalities, we should figure out why.
Yeah, it's
I totally agree with that.
Probably inflammation as it's traveling through, and there's heat in there.
Exactly.
Is that heat from sitting down, or because there's some kind of
varicocele
low grade
inflammatory?
Yeah,
I totally agree with you.
Yeah. And then we don't have the time to get into the energetics of what's creating that heat too,
Oh yeah, exactly.
Yeah. So real quickly, our mutual patient. So anything more you want to say
we
about
didn't talk about genetics, which I think maybe we should touch on
like
really quickly. Yeah. So especially when the setting of recurrent pregnancy loss, you want to make sure that people aren't carriers of a balanced translocation. And what a balanced translocation means is, if you Google a picture, you'll see actually a really beautiful picture of a karyotype with, you'll see that one chromosome has a little piece of it missing, but that little piece actually made it onto another chromosome. So all your chromosomes are there, but just a little piece for you is over here. But now imagine when you're trying to have children, now your chromosomes have to divide. So now one little piece of that piece of the chromosome that has the extra or that is missing a part of the total gene will be making it to the embryo. And then that embryo is not going to have a normal amount of DNA, and that can lead to recurrent pregnancy loss. So that's something that we worked up for our patient as well. And hers were normal.
Okay.
Yeah.
And so that's called just the karyotype, or
yeah,
is there some
just a
other
karyotype?
Okay.
Yeah, just a karyotype for both partners, because that's not just on the woman. That could be from either or. And then the carrier screening is another good thing that we always do. That, one of the carrier screenings will screen, the way that we practice at CFP is that we do the expanded panel, because we just think if we're doing this, we should just get all full information. That's kind of our practitioner's approaches. But we'll check for over about 500 genetic diseases that if you carry by yourself, it's not a big deal. Think of things like cystic fibrosis, spinal muscular atrophy. But if you and your partner carry it, then there's a 25% chance that your child could have this. And I always try to phrase it to my patients like, we're making embryos. We need to be responsible about it too. We need to make sure that we're at least screening for everything that we possibly can at this current, 2024. All the genes that we know about that we can screen for, we should screen for that. But one thing that kind of comes up on there that's, I think, important for this specific conversation is that when you're screening men and women, you can pick up on Fragile X disease too, because that's a recessive disorder. And Fragile X disease may lead to premature ovarian insufficiency for women, or maybe they'll have no symptoms from it, but it might progress as you have future generations, because Fragile X disease actually just gets worse as we conceive. So it's a little bit out of the scope of our conversation right now, but another good thing to make sure that your patients have counseling about, because we're just being responsible about the embryos that we're creating, and then also educating people about their overall health. Mm-hmm. Yeah.
Right. Well, that's the point of this whole thing,
exactly.
Isn't it? Like, to give people information.
That's exactly right.
Yeah. I think in the context of our mutual patient, I want to just bring in one more thing, the thyroid.
Yeah.
In the context of a standard workup, the thyroid needs to be optimized.
Yep.
And the range is like 2.5 or below, right?
Yeah, exactly.
TSH.
Yeah, the TSH. We generally like it to be 2.5 or below. That's another debated topic though. And the data on your TSH needing to be that low is debated. Some people use 3.0, but even that, it's still normal, right? It's if you're not trying to conceive, that number is a normal number, and your primary care doctor probably wouldn't do anything about it. We just think in the fertility world, trying to optimize that number as much as we can could potentially improve live birth. And being on Synthroid, I mean, I don't want to belittle being on any medication, but being on Synthroid or any sort of thyroid hormone replacement usually doesn't have very many side effects, and actually can sometimes make people feel better too. Like the thyroid's like a happy hormone. So, it's not a very intense treatment to try to bring that number down. Every now and then we have patients that don't want to be on any more medication than they need. And then, we'll talk about that specific case, but most people are pretty receptive to being on thyroid medication to try to optimize that number. Mm-hmm.
So if the TSH is too high,
yes,
like what level?
Like over 5 or over 4.5 generally. You'll also want to make sure that you're seeing like a medical endocrinologist, because then they'll do a further workup to check for anti-thyroid peroxidase antibodies, and just make sure that there's no sort of immunologic factor. Another hormone that comes up often is prolactin. Mm-hmm. And so prolactin being elevated, if your first prolactin is elevated, then we repeat it, because sometimes people's prolactins are just elevated. If you've just recently eaten, if you had any sort of like sexual stimulation, that can be elevated. So I always make sure that we repeat it again in the follicular phase of somebody's menstrual cycle while they're fasting. And we always say, no intercourse that morning. It's a silly thing to say sometimes, but we just want to make sure that we're ruling everything out. And if it's still elevated on the second one, then we'll recommend speaking to a medical endocrinologist and doing a MRI of the brain. That's just to make sure that there's no little adenoma or benign growth, exactly, on the
tumor.
pituitary that's releasing prolactin. If there is, you can start medication for that too. That will easily bring your prolactin down and hopefully improve our chances of conceiving.
Yeah. Right. So many different things.
So many
to check
things to
off
think
of the
about.
box, like
Yes.
the ovaries, the uterus.
Yeah, we didn't even talk about the brain. Yeah, yeah, you're right.
The different things that could go on in the brain.
Exactly.
Hypothalamus.
Exactly.
Right. But it's this holistic system and kind of a checklist. And I love how you sleuth it out. And with that particular patient who's gathering information.
Yes,
right
we're
now.
in information gathering mode while trying to conceive. As you know, the months that we can, that we're not gathering information, we're still trying to conceive. And I'm very hopeful. I'm very hopeful for her. I think she'll do great.
Me too.
Yeah.
Well, thank you so much for sharing all this information.
This is so fun.
Thank you.
I'm a nerd, so this is like really fun for me to talk about all the different parts of the puzzle. So that's
for
great.
me too.
Yeah.
Thank you for being a part of this bridge we're making.
Of course. Thanks for having me, Danica.
Yeah.